So, greetings everyone with this very eventful and happening beginning. And I know some of you have not reached us as yet. We'll watch this later. So, welcome to another episode of Oral Pathology Tuesdays. On every Tuesday, we go live here to discuss and hear about oral pathology, oral medicine, oral radiology, and everything that's basically got to do with the diagnosis of head and neck, especially the oral and maxillofacial lesions. And on a normal day, I think everyone who is here can tell you that we do not have this many incidents. So let's get on with it. Today, first and foremost, I should wish everyone from the Indian Fraternity of Oral Pathologists for the Indian National Oral Pathologist Day, which just happened. It is to mark Dr. H.M. Dholakia's birthday. He is the founder of oral pathology in India. And I must say, I was very, very fortunate personally to have him both as my teacher in my BDS and MDS. He was my guide. So there's much I have learned from him, much I owe him. And he's very always, not just on his birthday, on every day, he is there with us. And with that, today's topic is in fact something he was very fond of. It's odontogenic lesions. And it was very common for us to, actually speaking, every time he got bored, from my memory at least, and I may be wrong, but every time he got bored during a seminar, he used to be scribbling on a pad and he was trying to work out the whole development of these lesions based on odontogenesis. And it was very interesting. Of course, it also said that he was getting bored with the seminar, but that's a different matter. It was a good pointer to us that we need to buck up and do a better job. On the channel, we have other lectures, both on ameloblastoma itself, related to odontogenic. We have a whole playlist. If you scan that, you will go to the playlist. It is also there, of course, on the description and also the heading of the channel. If you just look on the playlist, you will find it. With this, let me say we are very happy today to have with us Dr. Yoita Prabhunath, who is a professor in the Department of Oral and Maxillofacial Pathology at Vivekananda Dental College for Women in Tamil Nadu. Now, this is a topic that's very close to his heart, and I just realized he's even done his thesis on this. He's been working on this for the last 12 years. There's much interest and his own passion, and there's much interesting things he's found that he's going to be sharing with us. And today's talk is going to be about other things in the treatment of ameloblastoma, which we know is otherwise very, very invasive and very destructive. So, this is a very interesting talk. And welcome, Dr. Prabhunath. It's lovely to have you with us.
Good evening, ma'am. Thank you for having me here, and I'm happy and humbled to be associated at this platform on this Oral Pathology Tuesday forum. And I take your permission to wish everyone a National Oral Pathologist Day from my side.
Yes. Yes, thank you. And it is always a pleasure to have young rising stars and people who are. It's a pleasure to have any of my speakers, but I must say some are always even more. Uh, how should I say this? For me, as a teacher and someone who is now fairly old and on my way to retirement, probably, it is always good to see that the next generation is so enthusiastic and going to keep things going ahead. And we can definitely leave oral pathology in very effective and well versed hands. So, with that, let's go watch the lecture and then come back. In the meanwhile, I will try and get everyone else to come and join us here. Yes.
Good evening once again. Greetings from myself and from my institution, Vivekananda Dental College for Women. I'm happy and humbled to be a part of this Oral Pathology Tuesday program. I would like to thank Dr. Mandana ma'am for having me in this august platform. Today, I would like to share my thoughts on the topic Beyond the Scalpel, Unveiling the Future of Ameloblastoma Treatment. The history of medicine shows a remarkable journey of how we humans have approached different illnesses and diseases from the early periods till date. Early humans were unaware of the various diseases and their medications. Magic and religious prayers played an essential role in prehistoric medicine. The practice of surgery dates back to ancient civilization where crude instruments and limited understanding of anatomy made procedures risky, while shifts in anatomic knowledge and technical skill empowered the surgeon, allowed for the advancement in the internal surgery and success in the surgical procedures we see today. With advancement in technology and molecular investigation techniques, we experience this radiation therapy and molecular therapy, which we call it as targeted therapy. Before going into the topic, I would like to share some interesting facts on the existence of ameloblastoma in prehistoric era and record of ameloblastoma in ancient history. Ameloblastoma was identified in a dinosaur fossil with an expansile jaw tumor which was estimated to be 67 to 69 million years. An ancient Egyptian mandible dated back to 2800 BC showed multilocular cyst suspecting of ameloblastoma. So coming to the background, odontogenesis, as we all know, it is a complex but highly orchestrated process where multiple tightly regulated genes works together and express themselves in spatial and time-bound manner. If any dysregulation happens between this signaling process, that will result in odontogenic lesions such as odontogenic cysts and odontogenic tumors. These odontogenic tumors originate from the odontogenic apparatus or its remnants in the jaws. They have differed histologic pattern and biologic behavior, but they show similar histologic cells and malformed structures seen during odontogenesis. Earlier, etiological theories were related to trauma, oncoviruses, inflammation, nutritional deficiency, irritation from extraction, and dental caries. Ameloblastoma, as we all know, it is the second most common odontogenic tumor arising from odontogenic epithelium, and it holds a peculiar position because even though it is considered as benign, it is very aggressive and highly invasive. The word ameloblastoma derives from early English and French term esmail, which means glossy glaze, which gives the meaning as enamel, and the Greek word blastos, meaning germ. In 1997, Robinson has beautifully described ameloblastoma as a benign tumor that is usually unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. So we have to note this word non-functional. In 1991, WHO defined ameloblastoma as benign but locally aggressive tumor with a large tendency to recur, consisting of proliferating odontogenic epithelium lying in a fibrous stroma. In 1992, WHO again defined ameloblastoma as a true neoplasm of enamel organ which does not undergo differentiation to the point of enamel formation, which means the cells seen here are non-functional. So, according to the best of my knowledge, through the thorough literature search, this was the only tumor which has underwent so many revision for its terminology. So few of the terminology we came across is our cystic adenoma, adamantinum, epithelium adamantinum, adamantinoma, and finally in 1929 and 1932, Churchill and Ivy have given the term ameloblastoma. Even after that, there are so many controversies to uh, uh, to give different terminology for this tumor. These are some of the synonyms which are given to ameloblastoma with non-specific to the ears. Even in the classification of odontogenic tumors, ameloblastoma is continuously going on revision from 2005 to 2017 and now in the recent classification of 2022. So earlier, the desmosplastic type, which was considered as one of among the clinical type, uh, that has been removed from the clinical type, and it is now considered as an histological variant. And the term solid multicystic has been eliminated, and now the usage of the term is conventional type of ameloblastoma. And the important modification is the metastasizing type of ameloblastoma has been brought under the benign odontogenic tumor under ameloblastoma. So these are all the frequency of incidence of ameloblastoma. When it comes to conventional type of ameloblastoma, it is 91 percentage with the histological variants of follicular, plexiform, acanthomatous, granular cell, basal cell, keratopapillary, and desmoplastic type. And 6 percentage accounts for unicystic type, which shows luminal and mural type of histological variant. 2% of peripheral ameloblastoma and 1% of metastasizing ameloblastoma were also reported. If this ameloblastoma left untreated, they often cause facial asymmetry, displacement of teeth, malocclusion, and pathologic fractures, which leads to wide tissue destruction and deformity. Surgery is the mainstay of treatment. However, as conservative surgical resection is associated with higher recurrence rate, wide en bloc resection with 1 to 1.5 centimeter bony margins is frequently recommended. Large ablative defects created by such en bloc resections are usually beyond the potential of bone self healing, and it needs some bone grafting procedures. So these are all the certain treatment regimens which is proposed for surgical treatment of ameloblastoma, and this treatment regimen is based on the anatomical location of the lesion, whether if it is present in the anterior mandible or posterior mandible or anterior maxilla or posterior maxilla. And the treatment regimen varies based on its radiological appearance, whether it is unicystic lesion or multicystic lesion. If the lesion is unicystic, the treatment regimen starts from a simple curettage and enucleation, and if it is multicystic and if it is huge in the posterior maxilla or posterior mandible, the treatment will be up to partial or total maxillectomy or hemimandibulectomy. And in the second uh, table, if you see this existence of ameloblastoma along with the adjacent structures like its involvement in the orbital floor or its involvement with the periorbital area and its involvement with the orbital contents and involvement with the uh, skull base. So based on this, again, the treatment regimen is proposed from partial maxillectomy to combined regimen of total maxillectomy with orbital accentration and skull base resection. The recurrence rate of ameloblastoma are 15 to 25% after radical treatment, and 55% to 90% after conservative treatment. 2% of recurrent ameloblastoma will turn into metastasis, which is termed as malignant ameloblastoma or metastasizing ameloblastoma. And again, 2% of recurrent ameloblastoma will transform into ameloblastic carcinomas, which is a malignant counterpart. According to the WHO classification of head and neck tumors, the lungs are the most common site for metastasis of ameloblastoma, occurring in 70% of the cases. The next most common sites are lymph nodes and bones. Lung metastases are often caused by tumor cells nesting in the distal arterial pulmonary circulation. So, ameloblastoma is considered as a radio-insensitive tumor for conventional radiation therapy. Hence, radiation therapy is of limited use and furthermore should be avoided due to serious, immediate, and late sequelae. Based on the radiotherapy treatment guidelines, dosage of at least 45 to 50 Gray units in conventional fractions were necessary, and the lymph nodes need not to be included unless the clinical involvement was apparent. So here are some interesting criteria to evaluate the result of radiotherapy through by histopathologically proven ameloblastoma cases. Number one, if a clinical enlargement of the jaw has decreased after radiotherapy, then obviously the tumor is radioresponsive, although it has not necessarily been eradicated. If the radiographic appearance of the tumor decreases in size after radiotherapy, that is, if partial reossification has occurred, the treatment has had some effect but not necessarily cured the lesion. If the radiologic appearance of the lesion is increasing in size, then the radiotherapy obviously they are radio insensitive and did not control the tumor. If the radiographic appearance of the jaw does not change after radiotherapy, there are only two possibilities exist. One, the radiotherapy has had little effect on the tumor and residual tumor is present, and the tumor has been destroyed by the radiation, and the remaining radiolucency consists of fibrous connective tissue. Reossification, as noted in the radiograph, is not necessary to have a cure. However, the only way to determine which of these two possibilities is present by the histopathologic examination. So, histopathologic evidence of residual or recurrent tumor is a proof that the radiation has no control over the tumor. Post-radiation follow-up examination must include annual radiograph. Simple examining patient of clinical examination is totally insufficient. So if you see the last point, at least 10 years of follow-up of the radiation patient treated with radiation therapy is necessary to say the success of this radiation therapy. As the technology advances, uh, after the introduction of this carbon ion radiation therapy and volumetric modulated arc therapy, so which has been proven effective treatment option for ameloblastoma, they can be given as exclusively treatment which is not combined with surgery. Although radiotherapy can shrink the size of the ameloblastoma, the tumor expanded the jaw or broken into the soft tissues does not appear to be a suitable treatment for an operable ameloblastoma. So in clinical practice, radiotherapy is mainly used in inoperable cases. So this picture is a pre-treated and post-treated pictures with carbon ion radiation therapy, where the arrow mark shows there is the notable reduction in the tumor mass and the size. So coming to the histology of ameloblastoma, so this tumor goes under four different phases: proliferation, apoptosis, matrix degradation, and invasiveness. So the central stellate reticulum cells goes for apoptosis, and the peripheral tall columnar or ameloblast-like cells, that is functionally immature cells, which is again functionally important to produce enamels, they are responsible for the proliferation of this tumor. And the induction phenomena which happens immediately adjacent or juxta epithelial induction phenomena, they are responsible for this initiation of matrix degradation process, and the epithelial mesenchymal uh, transition is responsible for the invasiveness of this tumor through matrix metalloproteinases and rankle proteins, which results in the expansion of the bone. And I would like to thank Dr. Sankeet from Hack Dentistry for this beautiful animation. So he's a good friend of mine for a very long period. And traditional chemotherapy has been unsuccessful in ameloblastoma due to lack of continuity in molecular signaling pathways and understanding of complete tumor biology. So these are all the conventional chemotherapy which has been tried over the past decades, but the result is not as appealing as we think. But few chemotherapies or like combined regimen uh, of chemotherapy, like carboplatin with placitaxel, or dabrafenib with teramatinib, and vemurafenib or MAID, that is MAID regimen. They showed an excellent result for ameloblastoma, which showed metastasis either in lungs or some other parts. They showed an excellent result, but they are not a targeted therapy. They are not specifically act towards a particular mutation. So uh, the treatment or uh, the picture of or the real happening of what is happening inside the tumor when this chemotherapies are administered or it still remains questionable. Over the years, there are so many proteins or and mutations has been studied with ameloblastoma, but in 2016, the breakthrough was the discovery of BRAF mutation in ameloblastoma. So there are three main mutation occurs or responsible for the pathogenesis of ameloblastoma. One is Hedgehog pathway or WNT signaling pathway or MAPK pathway, where this BRAF mutation comes under. So Gomes et al. Hypothesis that there is a crosstalk between this VNT and beta catenin pathway, SHH pathway, and MAPK pathway. So this is a very good systematic review and meta-analysis uh, done by Gultekin et al., where the mutation has been analyzed with uh, different ameloblastoma cases, and the most follicular subtypes showed BRAF or multiple gene mutation, whereas multiple plexiform and mixed variant shows single mutation with SMO, NRAS, HRAS, or EGFR. The recurrence rate was highest in the group of ameloblastomas with multiple gene mutation. Tumors with BRAF mutations revealed significantly lower risk for recurrence, and the tumors with SMO gene mutation appear to be associated with higher recurrence rate. Moreover, multiple gene mutations were exclusively present in solid ameloblastoma, which accounted for 100%, whereas peripheral type of ameloblastoma revealed single stomatic mutation in BRAF or SMO. Most follicular subtypes shows BRAF mutation and multiple gene mutations, whereas most plexiform and mixed variants displayed either SMO gene mutation or NRAS, HRAS or EGFR mutation. So again, in 2021, researchers from Israel, they had a very big breakthrough by treating three pediatric ameloblastoma cases with a dabrafenib drug. So all the three cases were from 10 years to 15 years of age, and no surgical intervention was done. And here, if you see, you can able to very well appreciate the formation of bone uh, over the tumor area. So 6 cycles were administered over 6 months of time. So this was one of the very big breakthrough recently happened in related to ameloblastoma treatment. So here is the link where if you uh, go into this link, you can see a beautiful video demonstrating the 3D uh, images of the tumor, which is shown in the jaw pre and post operative pictures and videos has been posted here. So now coming to my area of interest, like during my post graduation, as a second year postgraduate, in the beginning of my second year post graduation, just like any other postgraduate student, I was told to select my dissertation topic. So I directly went to my guide and my mentor, Professor Dr. Madhav Nirmal sir, and I told, sir, I'm totally blank. I don't know how to select a thesis topic. Uh, and I asked him which area I should select, whether I should select a oral cancer topic or dental caries, or how to go about this, because I'm absolutely blank about this thesis topic selection. And he told me, like, our institution is like 30-year-old institution. We have a very good number of ameloblastoma cases. And if you are interested, you just go and search some literatures for ameloblastoma study. So we can proceed. If you are still interested to continue with the ameloblastoma, then we can proceed with this the study in ameloblastoma area. So uh, since my third year undergraduation, we all like this ameloblastoma topic, because it is frequently asked 10-mark question. And since my third year of undergraduation, I like the definition of Robinson's definition of ameloblastoma, frequently asked viva question also. So I went and I searched in Google. So these two articles, uh, uh, if I say it frankly, they have it has changed my life actually. So one is, are we in the brink of non-surgical treatment of ameloblastoma? So being a junior, when I used to assist in grossing along with my seniors, so I used to wonder when I see a huge specimen comes from surgery department, so ameloblastoma cases, semi-mandibulectomy, en bloc resection cases, I would think, so why this much tissue has been taken, even though if it is benign. So this article really kindled my interest towards a non-surgical treatment of ameloblastoma, my exploration over the non-surgical treatment of ameloblastoma. And the second article I accidentally came across while searching ameloblastoma was the second one, the immunohistochemical profile of odontogenic epithelium in developing dog teeth. This was a study done in South Africa among the in the veterinary college. So they have uh, uh, showed a P75 neurotrophin receptor. Uh, First time I'm hearing this P75 neurotrophin receptor when I went through this article. So it is a neurotrophin receptor which showed the expression was found in odontogenesis of a dog, and the expression was there in tall columnar cells with reversal of polarity, that is pre-ameloblast cells. Once if it matures into ameloblastoma and starts secreting enamel matrix, the study stated that the expression was lost. So I thought like the similar type of cells are seen in ameloblastoma, that is functionally immature cells. Though these ameloblastoma cells, cells in ameloblastoma tumor, they cannot produce enamel, like it is non-functional cells. So I thought, why can't we try this P75 neurotrophin receptor in ameloblastoma cases? And I came out with this topic, and like my guide also readily accepted. So now, what is this neurotrophins and neurotrophins receptor? So we all know when a cell has to respond, signal has to be created through a receptor and a growth factor. A ligand has to be created, and then intracellular signal transduction has to take place. Then finally, the cell will respond. So this neurotrophins are a growth factors. So the neurotrophins are nerve growth factor, brain-derived neurotrophic factor, neurotrophins 3, neurotrophins 4 and 5. They come and ligand with the cell surface neurotrophin receptors like P75 neurotrophin receptor and tyrosine kinase neurotrophin receptors. So these neurotrophins and neurotrophin receptors play a major role in apoptosis, survival, and differentiation of neural and non-neuronal cells. And it also plays a role in survival, proliferation, differentiation, angiogenesis, metastasis, and chemoresistance in pathological neuronal and non-neuronal cells. So this all this neurotrophins and neurotrophin receptors were also expressed in neural crest derived cells. So that was my real spark that this ameloblastoma, since it arises from this neural crest, this odontogenesis is arising from this neural crest derived cells. So this neurotrophins, they either uh, form ligands with this P75 neurotrophin receptor, or they form the ligand with a tyrosine kinase receptor, and they can have a crosstalk with each other also. When they interact and they create a signal transduction pathway, this P75 neurotrophins receptor takes the cell for survival through nuclear factor kappa B pathway, and it takes the cell towards apoptosis through JNK pathway. So when the proneurotrophins can attach only with P75 neurotrophins receptor, and if it also makes a ligand with a co-receptor of sortilin, it directly takes the cell towards apoptosis. And this tyrosine kinase receptor, when this neurotrophin comes in, binds with tyrosine kinase receptor, they takes the cell for uh, survival, proliferation, migration, and plasticity, and they also responsible for the angiogenesis. So they take the cell towards all this function through either AKT-PI3K pathway or MAPK pathway, where this BRAF plays a major role, or protein kinase C pathway. So with this, I took after completion of my post graduation, I continued my doctoral research work in ameloblastoma itself. Now, during that time, I extensively studied all the neurotrophins and neurotrophins receptors among ameloblastoma cases, and I particularly selected follicular and plexiform ameloblastoma. These are all the few pictures from my earlier publication. I could not able to share the pictures of other markers in a public forum because those articles are accepted and they are still in press. So sorry, I couldn't able to share those pictures also. And what we came across, the interesting factors. So this follicular ameloblastoma showed more positivity towards P75 neurotrophin receptor, and this TRK were very mild or no positivity was seen in follicular type of ameloblastoma cases, and P75 neurotrophins were very less expressed or not expressed in plexiform type. So we uh, concluded our study like, so the follicular ameloblastoma takes P75 dominant pathway, that is nuclear factor kappa B pathway, and this plexiform ameloblastoma, it may take this tyrosine kinase A pathway, which is of this BRAF and AKT-PI3K pathway. So based on that, we did a pan drug analysis for what drug could be the best drug of choice, which targets all this neurotrophin and neurotrophin receptor. So far, as we already seen, this dabrafenib drug has been uh, uh, used to treat the patients, ameloblastoma patients with who are identified with BRAF mutation. But if you see, this dabrafenib drug can only act with this tyrosine kinase receptor A alone, not with any other receptors. So if ameloblastoma takes any other pathway through any other signaling system, this dabrafenib drug will be insensitive. So now what we are, how we are progressing our workers, like this is a kick map of neurotrophin signaling pathway. And if you see, so this is a cell surface where you can able to see P75 neurotrophin receptor and tyrosine kinase receptor. This P75 neurotrophin signaling system takes the cell to cell survival through nuclear factor kappa B pathway, and tyrosine kinase receptors, when it attaches with the neurotrophins, it takes the cell to cellular differentiation, cellular survival, and cellular plasticity through three different pathways, that is mitogen activated protein kinase pathway, where the BRAF plays a major role, and AKT-PI3K pathway, and protein kinase C pathway. So the interesting part is they can act independently. Both this group of receptor can act independently, but they can also have a crosstalk with each other. So now to uh, unravel the molecular biology of ameloblastoma. So the entire uh, signaling system has to be studied. So I think you remember uh, the previous slide where I have mentioned so many proteins which has been identified in ameloblastoma. So most of the cascade signaling pathways has already been identified, but they have not uh, formulated uh, or uh, coming to the summary and conclusion, ameloblastoma, if left untreated, they often cause facial asymmetry, displacement of teeth, malocclusion, and pathologic fractures, which leads to wide tissue destruction and deformity. Surgery is the mainstay of treatment. However, as conservative surgical resection is associated with high recurrence rate, wide end block resection with 1 to 1.5 centimeter bone margin is frequently recommended, but it affects the quality of life of a deceased person. Although radiotherapy can shrink the size of the ameloblastoma, radiotherapy does not appear to be a suitable treatment for an operable ameloblastoma. So, in clinical practice, radiotherapy should mainly used in inoperable cases. And the discovery of this BRAF mutation in ameloblastoma was a great breakthrough. And finally, the tumor cells of ameloblastoma could play a crucial role in the tumor growth by inducing all this pathway, that is AKT-PI3K pathway, MAPK pathway, which includes BRAF, protein kinase C pathway, nuclear factor kappa B pathway, and their cascading effects. So targeting this BRAF alone is not a permanent solution, which may take us to non-surgical treatment of ameloblastoma. But when we address all this signaling pathway through a drug, definitely I think we can uh, come up with a non-surgical treatment of ameloblastoma. So these are some of uh, my work which got published in relation with uh, uh, ameloblastoma. So as I already mentioned, are we in the brink of non-surgical treatment of ameloblastoma? And uh, maybe we have not succeeded in the at present uh, in the non-surgical treatment of ameloblastoma, but definitely in future we are very close enough to uh, break the bricks of uh, uh, to enter into the non-surgical treatment or non-surgical era. So the night will pass, the sun will rise. You may always carry a memory of the dark. Use it to become a better and more compassionate person. Just think for yourself when a pediatric or adult patient with a huge swelling comes into your clinic and diagnosed as ameloblastoma, and if you treat them with a non-surgical treatment, so they can have a very good quality of life even after the post-treatment. So if I have seen further than others, it is purely by standing upon the shoulders of my of the giants. They are which are my teachers. So this is my alma mater, Raja Mutaya Dental College and Hospital, currently known as Kadalur Government Dental College. Once again, I thank Dr. Mandana ma'am for this opportunity, and I thank each and everyone for the patient listening. So I just want to give a few suggestion for postgraduate students if you are listening to this lecture. So be careful while selecting your PG dissertation topic. So one good topic Well, I say definitely it will change your career. So don't do a dissertation just for the sake of doing dissertation or as a partial fulfillment of your post graduation. So when you have a, a a topic which is very close to your heart, it will really become your soul. So it will never leave you, and you'll definitely proceed and progress further in that topic. Thank you once again.
Thank you. That was a very interesting lecture and quite thorough. And my apologies to everyone again for the whole mix up. I'm sorry some of you might have missed the beginning of the lecture. Well, you can always watch it here. The recording will be available. And normally we don't have this much of problem. This was after a very long time, in fact, we had any problem. So, anyone has any questions, please put them in the chat. So while you are working on the questions, you can always hit the like if you like the lecture and if you like our content, because that really makes a difference in how often YouTube and Google will show this content to others. So do hit the like, and if you are new and you haven't subscribed, do hit subscribe too. Thank you. Yes.
I would like to add a few points here. Now, due to some
Sure.
technical, just some words of my presentation was missing there.
Yes.
So, like as I was telling about this entire pathway of neurotrophins and neurotrophin signaling. So, when we searched in the literature, so we found that so many uh, mutations has already been found out. And when I came back to this cake pathway, and I found most of the proteins or mutation which was already identified, they have not put it in order. That is what is needed. The correlation between the uh, proteins has been missing. So if we able to chain that correlation, I think definitely it is going to be a great thing in near future.
So Dr. Nasser was saying it's a very nice talk. Thank you. And Dr. Parinita also saying very informative and interesting topic. Right. Okay. We have a comment. Dr. Narayanan says, thank you so much for the amazing presentation, sir. Most of the informations were so new. And Dr. Sharma says, dabrafenib and trametinib combinations have given good results in some studies targeting both BRAS and MEC pathways. BRAS and MEC pathways, if that's how it's read.
Yes.
And Dr. Sharma also says thank you.
Uh, Actually, earlier it was like only targeting this BRAF pathway, and before that, randomly the chemotherapy was given, by not targeting a specific mutation. So whatever has been tried and approved with either oral cancer or some other malignancy, they have administered those chemotherapeutic agent in ameloblastoma. But after the identification of BRAF mutation in ameloblastoma, they have the concept of more personalized medicine are coming into existence.
Yes. Personalized medicine is really definitely the thing of the hour.
Yes,
And I think it's really very possible because now, with the, what I would say, the quantum of computing that is possible now and the analysis that is possible with all the I think we can really possibly move much faster towards personalized medicine.
yes, ma'am. That's what, as I already discussing with you before, not only as an oral pathologist we can achieve this. If we have a good communication or a rapport with a bioinformatics person, pharmacokinetic person, then the results will be more fruitful and quicker.
So there is, can the Israeli protocol for treatment of pediatric ameloblastoma be extrapolated to non surgical treatment of adult ameloblastoma?
Uh, Definitely. Uh, uh, so as I mentioned, it is like a personalized or targeted therapy. It is not it's a pediatric case or it's a adult case. So first, through incisional biopsy, we have to find out what gene is actually uh, taking the signaling pathway there. So accordingly, we can uh, administer the or we can plan the treatment regimen. So recently, we what we try to propose is like both follicular and plexiform type is not just an histological variant. They both are uh, total different biological behavior actually. So if you see from our result, my thesis result, so this follicular ameloblastoma is taking uh, NF kappa B pathway or AKT-PI3K pathway. But this uh, plexiform ameloblastoma is more oriented towards BRAF pathway. So if you administer a drug which targets BRAF mutation to an ameloblastoma case which goes towards AKT-PI3K signaling pathway, it doesn't work. So it is not like a pediatric case or it's an adult case. It is what signal the ameloblastoma is uh, taking or choosing, that is what matters to uh, deliver a precise medicine. And recently, uh, we tried it with a molecular docking after our research, and it has got presented in the last National IAOMP conference. So we actually proposed a drug name called as serasunofib, which means it targets all the three pathways, not only BRAF, that is mitogen activated kinase pathway, where this BRAF comes under. They also acts on this AKT-PA3K pathway and protein lipase C pathway. So that means that is what either we have to go towards a broad spectrum of agent which targets all the pathways, or else we have to identify according to the case which signaling pathway the ameloblastoma is taking in that particular case.
Okay. I think Dr. Bhuvan has a. Yes. Hi, Bhuvan. Okay. The recent research on the pathogenesis of many odontogenic cysts and tumors will be breakthrough for the treatment as PCTH4 OKC and BRAF for ameloblastoma. Oh, I
Yes,
think.
actually, Dr. Bhuvan, actually, it is known that that is why the controversy occurred as whether it is OKC or uh, KCOT, keratocystic odontogenic tumor. The three reasons what they told us: one, clinically they are very aggressive, and histologically there is a basal cell proliferation is there, and genetically it showed a two-hit mutation at PTCH gene, that is patch gene and SMO gene. But later again they put back it to the cystic classification OKC. But if you ask me personally, all these signals, whether it is a PTCH gene or if it is a WNT signaling pathway or mitogen activated pathway, they all have a crosstalk between each other. So if you can able to silence one gene, you can that is definitely it is possible to silence or nullify the other signaling pathways also. So there are many literature evidence states that this if we silence this VNT beta catenin pathway, it also silences this mitogen activated protein kinase, that is MAPK pathway. So it is a complicated or it's a complex signaling pathway, but the thing is we have to precisely identify what uh, mutation has happened in that particular patient and the particular disease.
Right. I think he has a follow up to the question, which is to the statement. I think now is the question. So I want to ask that BRAF mutation causes other cancers like melanoma, papillary thyroid carcinoma, sir. Have you come across ameloblastoma with other cancers caused due to BRAF mutation?
Vaguely, I remember along with ameloblastoma, the similar pattern of mutation is identified with this basal cell carcinoma. So, most of the drug of choice, what they are advising or prescribing today for ameloblastoma, is already proven with other cancers. Because the other cancers, if you take cancer or any tumor, so all the tumors they the basically the platform of signaling pathway is going to be the same, so it never changes between ameloblastoma or whether it is a melanoma or papillary thyroid carcinoma. So once if they already a drug is already proven with the other cancers or malignancy, they try to incorporate the similar kind of therapeutic agent in the ameloblastoma or the tumor of our choice. That is what happens.
Yes. So we don't really have any questions. I'll just share the little bits of news I have and then we'll come back in case anyone has a question again. So the first thing is to bring to your notice that if you remember, I was telling everyone to take part in the open mic. Well, now is the time for the actual event, and it's going to be there on the 1st of March, is the first part. So, the live event one, seven people will be taking part, and it's at 6:30 IST. And you or the audience will be voting for the winner. So, please make it a point to attend. Of course, since we are troubling you to attend, we are also going to give you some gifts. Among those, basically, are going to be two coupons to get a 50% discount to register for the conference. Since, anyway, all this is about the conference, as we had mentioned before, the winner of this session will be one of the guest speakers for the conference. So, please share it, please keep an eye and be a part, decide who you're going to listen to in the conference. It's going to be, well, your vote. And the other thing, of course, is the conference itself. The registration is open, it's on our website. You can also scan this and go there. You can also, of course, now the entire description is gone from below this video, but I will put it back. And basically, you just have to go to our website. Even on the homepage, you scroll down, you will see the conference's details, and you can click on that. You will go to the conference page. So the early bird discount of 15% is on. Please take part, and of course, the abstract submission for case presentations and case series presentations for both single cases and case series, both oral and poster presentations also will open in the next 2 days. So please go check it out. It is quite interesting, like last year, and you can find out what all happened in the last one we had in 22. So you have a good idea of what's happening there. It's all there on our website, and we do hope to see you and definitely share it with others. Okay, let's come back here and see what's happening. Okay. So let me say thank you. And I do hope you will be back again on the channel. And I do hope you will continue your work on ameloblastoma and become our expert in this part of the world on ameloblastoma and
Thank
eventually at the global level.
Thank you so much, ma'am, and I'm so happy and blessed to be a part of this forum. And thanks for the opportunity and appreciation from the senior people like you is such a blessing, which makes us to run an extra mile with so much of energy, actually.
Wonderful. But really, Oral Pathology 360 is nothing but all the people who are in it, all the speakers, all
Exactly.
the people participating, all the people commenting, turning up every week. Uh, that's what Oral Pathology 360 is. So it's for all of you. And no, the chat is still not connected. So let's just go on. Thank you so much. I'm sorry your lecture had so much of things happening to it, but like I said, today there seems to be an overall problem with network everywhere because apparently even YouTube is having it. So take care and do come back soon. Actually, you are coming back in the open mic, aren't you?
Yes, ma'am.
In the second one.
Yes,
Yes.
ma'am. I'm preparing for it.
Yes, I just remembered. I just remembered. So we will see you quite soon. The second
Yeah.
part of open mic is on the 12th of March.
Mm. Yeah.
Yes, so we will see you then. Okay,
Yeah.
thank you. Thank you so much.
Thank you, everyone.
You're most welcome. So now coming to sharing next week. Next week we have Dr. Evgeny Denisov. He is going to talk about multiomics in early onset oral cancer. He is a bio he is not a dentist or a medical person, but he is from the bio research side, and he has been working a lot on cancers and then has moved on to early onset oral cancer. Has a lot of interesting insight on what has been happening, and we'll find a lot of new things from him. So, like Dr. Yoitap was saying, interdisciplinary interaction. So, this is what it's going to be, and I do hope you will all join us. With that, let me say bye and let me say see you all next week. Till then, be safe, be well. See you.